My name is John Page. I'm a consultant gastrologist here at Tumor Hospital, and I've been in post for over 20 years. I'm the chair of the Cancer Unknown Primary CUP MDT here at Sunderland. So this is a quick overview of the role of the MDT. So the MDT is an advisory body which gives advice to clinical teams as to how best to manage patients. The focus is on trying to get the best patient-centred care for each individual patient. Unfortunately, for Cancer Unknown Primary, which accounts for approximately 1 in 20 of all cancers, by definition, the cancer is incurable. Most of these patients are elderly and frail and require careful consideration as to whether or not they are appropriate for palliative chemotherapy and other intervention. Often, the best and kindest thing for these patients is best supportive care, with end-of-life supportive care in the community or in the hospital. We have very good specialist nurses who help support us, providing holistic care for each individual patient, and we have good links to the palliative care team working in the community and in the hospice. The vast majority of patients with Cancer Unknown Primary will have undergone a CT scan to determine that that is the clinical diagnosis. There's then a careful consideration as to whether or not the patient is strong enough and wants to be considered for palliative chemotherapy. Many patients are old and frail and would not be appropriate for this. Namely, such treatment would actually make things worse for them, reduce their quality of life, and actually may bring their death sooner. We will offer patients biopsy to get tissue diagnosis to confirm the diagnosis and to guide palliative chemotherapy treatments if patients want us to do this and if the patient is deemed to be fit enough to be able to tolerate palliative chemotherapy. We very rarely undertake biopsies otherwise, as this is of no benefit to the patient and just runs the risk of complications. We are often asked what is the role of tumor markers in people with Cancer Unknown Primary, and the role is very limited. We do it in very few circumstances, and in most cases it's of no benefit. So as a general rule of thumb, we discourage the use, and we as a specialist team will advise when we think it might be of particular benefit in each individual patient. And this is decided on a case-by-case basis. A patient with the Cancer Unknown Primary almost certainly by definition have incurable disease, namely because we've picked up spread of the cancer to another site on a scan, usually an ultrasound scan or a CT scan, but we do not know where it has spread from. Therefore, the focus of treatment on these patients is palliative care, which may or may not involve palliative chemotherapy or radiotherapy, but often patients are elderly and frail, and these patients do not benefit from chemotherapy or radiotherapy. In fact, this will make their quality of life worse. In these patients, we're trying to concentrate on symptom control, accessing the palliative care services in the community and via the hospice where appropriate, to try and give these patients and their families the best quality of life possible for as long as possible together. It is important to focus on the quality of life, and it's also important to focus on, ultimately, what is a good death rather than an awful death. We're very lucky to have the input of our specialist nurses who help us deliver holistic care on an individual patient basis, and that is the prime focus of the care that we deliver. We very strongly want to avoid unnecessary interventions, and we very strongly want to avoid giving mixed messages or unfair messages to patients with unrealistic expectations. I hope this is a helpful summary for you. If you have any uncertainties or queries about this, please contact me here at Tumor Hospital. Thank you for all your support and all the care you deliver for your patients in the community.